Good afternoon. Thank you everyone for joining today. Over the next 30 minutes, this will be the educational objective. One is to introduce the types of biomarkers. Next is to find out which biomarkers are to be used in what situation, and some insights regarding recent trends in this particular. I'd like two cases. The first, that of Mr. M, who is a 24-year-old male student, was arrested for driving under intoxication on the 11th of July. The breath alcohol was positive when checked by the traffic police at 9 p.m. on the same day. He was kept overnight at the police station and was produced in front of the doctor for an examination at 10:30 a.m. the next day. The question is, what should be done next? And the repeat breath alcohol that was done the next day turned out to be negative. The next case we need is that of Mr. S, a 35-year-old male who's been recently recruited to be an ambulance driver. On the first day of duty, however, the supervisor has detected the smell of alcohol in his breath. The driver, however, claims that he did not drink alcohol. The breath alcohol testing was done and was found to be negative. The question is, what should be done next? We will address these questions during the later part of this. Now coming to what is a biomarker. Biomarker is any biochemical substance in the body, and one of the definitions is any characteristic which can be objectively measured and evaluated as an indicator of one, biological processes, if there's a derangement of the biological process, pathogenic processes, or any therapeutic intervention, what are the pharmacological responses? Any substance that does all this can be considered to be a biomarker. Now, what are the various purposes of biomarkers? One, the patient gets admitted, and then you want to know whether there's been problem drinking, alcohol-related tissue damage, to monitor during the course of treatment, and also to give a feedback during motivational interviewing. The other uses are during clinical trials and in high-risk situations like pregnancy. Now, biomarkers can be classified in multiple ways, and two of the ways are, one is state versus trait biomarker. A state biomarker is what the focus of today's presentation would be, which gives information about the recent drinking patterns. A trait biomarker, which is mainly genetics and other biomarkers, they tell us about how much the person has a risk for dependence. For example, individuals with family history of alcoholism are 3 to 5 times more vulnerable. The other way of classifying is direct versus indirect biomarkers. The direct biomarkers are directly derived from alcohol and the products of alcohol. Like for instance, blood alcohol itself, ethyl glucuronide, acetaldehyde products, acetic acid, fatty acid ethyl esters, ethyl sulfate, and phosphatidyl ethanol. The indirect biomarkers don't per se measure the amount of alcohol, but detects the effect that alcohol has on other body organs or body chemistry. Like for instance, MCV, which is mean corpuscular volume, and in liver, the GGT, SGOT, SGPT, which will be described in further detail. And also find structural changes in the biochemistry of blood like CDT. Now, any biomarker has to have a few, an ideal biomarker has to have these following conditions. One, it should be 100% specific and 100% sensitive. And also it should directly correspond to the amount of alcohol that the person has taken and how long back he has taken the alcohol. And of course, practical issues like the sample should be very easy to obtain, readily testable, and the result should be very quick. And overall, the test should be very inexpensive. I would like to mention that no biomarker is ideal. Now, just a small about sensitivity and specificity. Sensitivity is any person who has the disease turns out to be positive. So if you have 100% sensitive, it means that every person who has a disease has been detected to have the disease, all 100% of them. This basically shows the number of true positives. And any screening test should have a good sensitivity. Now, specificity is once the proportion of patients who don't actually have the disease and they're supposed to test negative. 100% specificity means that it correctly identifies every person who does not have the disorder and the test turns out to be negative. These are called the true negatives. Metabolism of alcohol. Alcohol, once ingested, it mainly gets absorbed in the small intestine and to a lesser extent in the stomach. It's eliminated mainly by liver metabolism and some part of it through urine, breath, and sweat. And 90% of ethanol is mainly liver oxidation by alcohol dehydrogenase and aldehyde dehydrogenase as depicted in the figure below. However, it's important to remember that at higher alcohol concentrations, the liver is unable to eliminate or process the alcohol, and hence there's something called zero order kinetics, which means that the alcohol elimination is not dependent on the time or the concentration of alcohol. Once alcohol is ingested, the peak is reached between 30 minutes if the person is fasting to a maximum of around 3 hours. So the range usually lies between half an hour to 3 hours. And the metabolism rate is about 10 to 30 mg per deciliter per hour. And of course, metabolism of alcohol depends on multiple factors like age, gender, weight, presence or absence of food in the stomach, the percentage of alcohol that the person has been drinking, the number of drinks, and the other drugs interacting with alcohol. For example, with respect to gender, females have less body water and more fat. So since they have less body water, the concentration of alcohol in this is increased. Therefore, the peak levels of alcohol in females is also higher. And the other reason for that is alcohol dehydrogenase content in the stomach is also lesser in case of females. These are the oxidative and the non-oxidative biomarkers. As you can see in the top part of the screen, the ALT, AST, CDT, MCV, and GGT, they're all indirect biomarkers in the sense that this basically detects how much of an effect that alcohol has had in the body, because of which there's been hepatocellular damage, leading to rise in the titers of these biomarkers. The non-oxidative biomarkers are as mentioned below. These happen because alcohol interacts with glucuronic acid and conjugates that and forms these products, which will be described in detail. This is a figure that shows the time levels. For instance, in the first part that we see is short-term alcohol is detected by blood alcohol concentration, and the traffic police basically use the breath alcohol concentration direct measure. So this can be detected for up to 6 hours, sometimes for up to 6 to 8 hours, and a maximum of 12 hours. The intermediate term biomarkers are ETS and ETG, which is ethyl sulfate and ethyl glucuronide. And these are the urine which can be detected for up to 2 days. The other biomarkers, which are the long term, which can be detected for up to 21 days or 3 weeks, is phosphatidyl ethanol, carbohydrate deficient transferrin, gamma glutamyl transferase, aspartate transaminase, alanine transaminase, and mean corpuscular volume, which can be detected for up to 12 weeks. Now today we'll just focus on the direct biomarkers. We'll be focusing on blood alcohol and ethyl glucuronide. Now, blood alcohol is a direct measure of the amount of alcohol that has been ingested and gets absorbed into the bloodstream, and therefore it has a high specificity. And as I already mentioned, it's eliminated from the body within 6 to 8 hours to a maximum of 12 hours. And in regular drinkers, the alcohol elimination is faster. It's important to remember that urine ethanol varies widely and does not exactly correlate with blood alcohol level, although the urine alcohol levels is slightly higher than that of blood by about 30 to 40%. Now we come to ethyl glucuronide, which in urine, it can be measured both in blood and in urine, both in serum and in urine. And urine, it lasts for up to 90 hours. And as I mentioned, the blood alcohol lasts for only up to 6 to 8 hours. Now, where is ethyl glucuronide usually applied? One is in a high-risk group where you constantly have to monitor whether the patient is taking alcohol or not. Like for instance, in comorbid hepatitis, in monitoring programs, in studies, in pharmacotherapeutic studies, and also in liver transplant, where any amount of alcohol ingestion after liver transplant can be detrimental. Wherein there have been studies on self-report versus ETG also, and other forensic investigations. It's important to know that ethyl glucuronide can be used even when chronic use of alcohol is not present. And when breath alcohol is normal, which becomes normal after 6 to 8 hours after the person ingested alcohol, ETG can be a good biomarker to use because the other biomarkers are not that reliable in this sense. Now, how do we assess ETG? At NIMHANS, we have lab tests which include blood sugar, urea, liver function test, breath alcohol, which are part of the clinical evaluation at the Center for Addiction. And also, earlier, ETG used to be measured by gas chromatography and mass spectrometry, and now it's measured by liquid chromatography. Why this change has happened is gas chromatography used to be used, when used, can only measure ethyl glucuronide. But with the liquid chromatography unit, we can measure both ethyl glucuronide and ethyl sulfate. And there's a provision for adding other biomarkers like phosphatidyl ethanol. And one more thing is the run time is lesser, which means the results can be obtained faster if you use the LCMS. But these are equipments, they use big machines, and the initial investment is much more. So there is ETG spot testing that is available. It is very similar to the multi-drug kits that we use for polysubstance use, like for cannabis, for instance. But this gives you only a yes or a no, which means that the alcohol has been consumed in the last 3 days or it has not been consumed. And further quantification will have to be done by other methods. Now, what are the limitations of ETG, ethyl glucuronide? One is presence of UTI can lead to degradation, thus leading to erroneous values. Age, gender, cannabis consumption, and renal function can affect the results. The ones that don't affect the results are race, nicotine, body mass index, and body water content. And liver cirrhosis, importantly, which means to say that even if a person has deranged liver function test, the ETG levels would come out to be quite accurate. And also, in self-reported abstinence rates for 3 and 7 days, the positive predictive value and the negative predictive value is quite high. Now we come to the indirect biomarkers. We'll be discussing about GGT, SGOT, SGPT, MCV, and CDT. Gamma glutamyl transferase is mainly present in endothelial cells and is the most widely used marker for alcohol abuse. If there is a continuous alcohol use, the endothelial cells get damaged and thereby leading to increased GGT levels from the endothelial cells into the bloodstream. However, the sensitivity to GGT is only about 30 to 50%. And however, the advantages are that GGT is quite inexpensive and available in most centers. The disadvantages are that any endothelial cell damage can lead to increased GGT values like hepatobiliary disorders, diabetes, hypertension, and dyslipidemia. And also false negatives is a concern. Even if a person has been drinking 50 to 99 grams of alcohol per day, it's elevated only in about 1/4 of those people. Next, we speak about SGOT and SGPT. SGOT is serum glutamic oxaloacetate transaminase, which is same as aspartate transaminase. It's a sensitive and specific not for alcohol use per se, but for acute hepatocellular damage. Now, there are other indicators like SGOT by SGPT. When we take the ratio, usually if it's more than 2, it implies that it's an alcoholic etiology. But it's important to remember that only in chronic alcohol use for more than 10 years is usually when SGOT and SGPT will be positive, although acute high levels of alcohol can lead to increased SGOT and PT levels. If you were to do a single test between SGOT and SGPT, SGOT has to be preferred to SGPT as it's a little more sensitive to the liver. SGPT can be related to multiple things like heart conditions and renal disorders. And it's important to remember these markers are not very accurate below 30 and above 70 years of age. Next, we come to MCV, which is mean corpuscular volume. The mean corpuscular volume increases because alcohol has an effect on the RBCs. But it's important to remember that it has a low sensitivity and is unable to predict recent abstinence or consumption, and also has compromised specificity. Several factors may affect the MCV, like for example, the nutritional status, and has a slow return to baseline. So if a person has been abstinent and we check the MCV values later, they will not find much of a difference. Therefore, it's not a good choice as a relapse marker. How the advantages are, normally when we send a complete hemogram, we also send a peripheral smear. So it's very easy to get the values of the MCV. It's quite easy, inexpensive, and it has good value when combined with the other biomarkers. Next, we come to CDT. CDT stands for carbohydrate deficient transferrin. So it's chronic alcohol use more than 60 grams of ethanol per day. It alters the biosynthesis. So the transferrin molecule is attached to sialic acid, which has 6 to 8 carbohydrate moieties. The total number is what is measured in CDT. However, it's been found that a more specific thing is what we call as percentage CDT, wherein silo, that is with zero carbohydrate moieties, monosilo with 1 carbohydrate, disilo, tri, tetra, and pentatransferrins are the ones that are seen for percentage CDT. If a person has 2 weeks of chronic alcohol abuse, then we reach higher values of CDT and we can detect it quite easily. And after abstinence, for about 5 to 10 days, the CDT levels start normalizing. It finally normalizes completely only by around 2 to 4 weeks, which is half to about a month to become normal. And these are the values for the CDT. Normal range is less than 1.64. And as I mentioned, 1.64 to 2.36 is intermediate. And pathological range is more than 2.36. And the percentage CDT, what I mentioned, the ones with the asilo, monosilo, disilo, all the way up to pentasilo, is better than CDT. As for females, the CDT shows much lesser sensitivity. So CDT as a marker can be used as an indicator for relapse and as an indicator for abstinence. So if the CDT level were to be measured at the start of treatment and you measure it after 3 weeks and you find a 30% decrease, it means that it's more likely than not that the person is abstinent. And once a person is abstinent, if the person has alcohol use again, it will get elevated by 30% when you check it again. Such sensitivity changes contributes to CDT being more sensitive than GGT in detecting relapse during detoxification. However, they can be false positives, but they're quite rare in inborn errors, genetic variants, severe cirrhosis, not just minor alteration of liver functions, and kidney transplants. And generally, women tend to have higher CDT levels than men, regardless of their drinking history. This is just the summary of what we're discussing so far. As we've already spoken, the SGOT and the SGPT, their return to normal is quite variable, and they are characterized mainly by heavy drinking, and they of course have false positives. However, the GGT and the CDT, they will return to normal within about 2 to 4 weeks, and the type of drinking you need to have chronic use for just the last 2 weeks, and hence it's a good indicator of relapse and an indicator of abstinence, CDT more than GGT. Now the question is, since we usually send more blood tests than one, can a combination of biomarkers be actually useful? One is the CDT plus the GGT has been found to be more sensitive, but slightly lower specificity. Now if you compare, the comparative values are most useful. You take a blood sample when the person has come to you initially, and then to check for abstinence, you check the value after a few weeks. If you find that the GGT is more than 20% elevated, or SGPT is more than 20% elevated, or SGOT is more than 40% elevated. I've already mentioned that SGOT and SGPT always go in a ratio of 2:1. Even here the 2:1 ratio is maintained. SGOT is 40 and SGPT is 20. Other studies have mentioned that ETG, ethyl glucuronide, plus audit, as was mentioned the last weekend, is a robust measure of alcohol use. And it's been found that if we just take the audit score, the positive relative value is just 17%. If you take the audit score of more than 8, as compared to almost 50% when used in combination with at least 2 biomarkers. So 2 biomarkers plus audit, the positive relative value increased to almost 50%. Just like to mention some of the NIMHANS studies that have been done. This was a thesis study that was done, where a study with 108 patients comparing ETG, ethyl glucuronide, both serum and urine. It has been compared to breath alcohol, blood ethanol, GGT, CDT, MCV, SGOT, and SGPT, as well as we've compared to self-report. And as per the previous studies, self-report has been found to be largely reliable. And how we know this is the direct biomarkers, that is serum ethanol and breath alcohol, have been found to closely relate to the self-report. And the ETG serum and the urine, they correlated with the self-report, which means that they also correlated well with the direct biomarkers. And ETG was able to detect alcohol consumption much after the blood and breath alcohol levels were 0. This means that after the 8-hour window, it was found that ETG is still able to pick up the people who had consumed alcohol more than 8 hours back. And was also able to detect alcohol use for up to 4 days after single consumption. Although literature normally mentions about 70 to 80 hours, it has been able to pick up to 4 days. And during this study that was done, ETG urine was found to be better than ETG serum in detecting the time since consumption. So if you had to make a guess, as in whether it's more than 12 hours, 12 to 24, 24 to 48, ETG serum would be a better marker than ETG urine, thus providing a non-invasive method of detecting this. And there is ongoing research as part of a thesis on monitoring serial.
Thank you. Thanks a lot to all of you. And